Hello and welcome to Pain in the Podcass, your place to find out everything you've ever wanted to know about pain. My name's Dr. Joseph Parsons, and I'm joined by the wonderful Don Wigesoria and Dr. Joshua Craw. And today, we're going to be talking about psoriatic arthritis. Welcome in.
Hello and welcome to Pain in the Podcast. This is your bi-weekly hit of pain relief. This week we're going to be talking about psoriatic arthritis, which follows nicely on from our previous episodes on axial spondylar arthritis as well as rheumatoid arthritis. I'm joined by the lovely Don Wigesoria and Dr. Joseph Parsons.
Hello.
And you are?
And I am Dr. Joshua Crow.
and I am.
As always with Pain in the Podcast, we like to start with you getting to know us a little bit better. You can understand us as hosts, as people. So we'll start off with some facts and learning. So I suppose I'll start, shall I?
Please do.
Go ahead.
So, sort of pertinent to this topic that we're talking about is that my fact for this week is I'm really bad at treating my own psoriasis.
It's really, really bad.
He is bad at treating his own psoriasis.
I've got a patch on my scalp, and literally if I just treated it for a week, it'd be gone. It's been there for 3 years.
Josh is the classic doctor, which is that can identify diagnoses for other people, encourage them to get treatments, and then just completely neglects his own health.
Yeah, it's a terrible curse. It's a blessing and a curse.
It's astonishing how bad you are at this.
Yeah, do you know what it is? I feel like, especially since becoming a doctor, it's sort of like I triage everything. Like, is it going to kill me? No, okay, it's fine then.
Okay, so that's a very binary position there. Makes things easy.
Yeah.
For you.
So, Dom, what's your fact for the week? Give Joe some time to recover from that.
So my fact is completely unrelated. It's about chocolate.
Ooh.
And so whenever my housemate and I leave, go away for like longer than a few days, so like a weekend away, for example, we give each other, it's a very unhealthy habit, we give each other chocolate, like a bar of chocolate. And when I first
bring
moved
it
in,
back, or you give it prior to leaving?
Prior to leaving.
Okay.
And when I first moved in, he got me Cadbury's Dairy Milk, and then I had to confess to him that I'm not a big fan of Cadbury's chocolate. I know. I grew up with Galaxy, so that's my preferred.
Did they have Galaxy in Saudi Arabia?
They did, yeah.
What?
And
Is that like the big chocolate brand?
It was the big one, and it tasted so good. They had this chocolate milk that was just unbelievable. And so now every time he goes away, he gets me a bar of Galaxy, and I get him a bar of Cadbury's Dairy Milk. But I'm really hoping that he's listening to this episode because Galaxy's my second favourite chocolate.
Bum, bum, bum.
Extra fact. Nestle's Crunch bars are my all-time favourite chocolates. I know.
Terrible choice.
I just love the Rice Krispies in there.
Terrible choice just because of Nestle being an abhorrent company.
Okay.
But beyond
so
that...
is Cadbury's, I'm sure. I haven't discovered.
Well, Cadbury's recently got sold off, didn't it? They changed the sugar formula to put more sweeteners in now, and it's completely ruined the entire taste of Cadbury's, and it's completely
There
ruined my
you go.
childhood.
Ruining lives all over the place.
Whether it be by poisoning wells or changing sugar
But I mean,
formulas.
Joe, you can't really talk. Your wife also loves this chocolate.
She does love it. It's her favourite, but I will never buy it, so that's kind of bad for me, relationship-wise.
Joe, what's your fact?
My fact is also related to sweet things. My fact
My
is
wife. Sorry.
I was thinking the same. I just didn't want to ruin the podcast.
that... Staying in.
My wife! Sorry, I had to do it again.
My sweet wife.
So, yeah, my best baked products that I make are generally very obscure ones. So,
Bread?
Bread, yeah. No one's ever really heard of it before, Josh. How have you heard of bread?
Well, only through you.
Okay. No, I really like making a Portuguese dessert called aletria, which is like vermicelli noodle version of rice pudding, which is very tasty.
Oh, okay.
And also a Hawaiian dessert, which comes from like Japanese origins, called butter mochi, or mochi as I would say it, but they all said mochi over there.
I'm sorry, you said best baked products.
They are Josh doesn't like it because he doesn't like the gelatinous texture, but I think it's my best. And I've had
Wait, the one that you gave us, was that? Did you made that? Right?
I made it.
Oh wow. No, it was pretty good. As someone who's used to like gelatinous pudding textures, I thought it was quite good.
Thank you, Don.
Yeah.
I think it's one of my best. So yeah, I can make brownies and cookies and stuff, but actually
That's the easy shit.
the best ones I make
No,
are the weird ones.
Can I-
Do you know what your absolute best thing you've ever made in your entire life is?
Is it kashpuri?
It's absolutely kashpuri.
Okay.
Which I've still not had yet.
Have you not?
Oh my god.
No.
Okay,
Next
next
film
time you
and
come
set.
up, well, yeah.
Can I also give you another recommendation?
Yes, please.
One of my favourite things, and it's got a similar thing to vermicelli noodles, is kanafa.
Oh, I love kanafa.
Oh my
Ooh, what's
god, I
kanafa?
want to.
It's a cream cheese, or not quite cream cheese. It's a specific
It's
type
a
of
specific
cheese
type
from
of
the
like
Middle East,
Middle Eastern cheese, yeah.
and it's like a sweet cheese, and you
and
put
it's sandwiched between pastry.
vermicelli,
Yeah,
noodly,
the pastry on
crispy.
top is like this vermicelli noodly kind of thing, specific to the Middle East, and then they
dipped
just
in rose syrup.
It can be rose syrup.
because it's then
Yeah.
they like blowtorch it and it's crispy on top.
and then they drown it in like sugar syrup
And pistachio.
and pistachios.
It's really, really good. If anyone lives up in the northwest, a place that I used to frequent quite a lot is Syria Sweets in Rusholme, who do a really, really good kanafa. So if you're wanting to try some, or you just want to go a really long way to buy some kanafa.
All right, we'll have to go for a trip there. Josh, what's your learning for this week? What have you learned about yourself?
I'm not sure if I've mentioned this before, but something I've learned even more acutely this weekend is that I'm just greying very rapidly. I went to the barber's yesterday, and they cut my hair, and I've got glasses on, so I was like, I couldn't see it. That doesn't look like my hair. So
You had the glasses on and you couldn't see?
I took the
Oh, you
glasses
cut
off
the
to take
glasses
them off
off.
so they couldn't do the sides.
And he's just blind.
He's
He's
just
like a mole. when
I
he takes the
am,
glasses
genuinely.
off.
So I took a wad of hair. I took it up to my face so I could have a look at it. Genuinely.
Sorry, just the picture of just the image of you sat in the chair, and this is a new barber's. You've
never seen me before.
Yeah, you've never gone to this barber's before. It's fairly local to me, not to Josh. And just the image of you just in your chair, just grabbing the hair as it
my
falls
hair,
off your
not
hair.
their hair.
Yeah, that would be even weirder.
But just staring at it.
With your eyes really up close to
Yeah,
it.
so and it was just so grey. It was like 50% grey. My sides, it's just awful.
He must have thought you were a crackhead.
Well, the combination of that and then the psoriasis just going
Yeah.
everywhere. I had to leave him a good tip.
You went through a lot, bless him. Don, what have you learned about yourself this week?
I've learned that I should not be attempting Romanian deadlifts with a fractured spine. Because before I got any news about it potentially being a fractured spine, the previous morning I went to the gym and just tried to do an RDL. I didn't do the entire movement, but I knew that I couldn't do it because I just kind of stayed there in that position for a long time.
And he's been there ever since?
Just hinged at the hips. I've got good form, but not anymore. So yeah, I've learned
Well, I'm
not to
very
do
glad that you're not doing that with a fractured
Well, I
spine.
really liked it.
Anyone who's at home with a fractured spine or suspected fractured spine, a piece of medical advice we can give you on this podcast is please don't be doing Romanian deadlifts, especially if you've not had any consultation with your healthcare professionals.
But do let us know what you're doing instead. Maybe they're good, maybe they're bad. I want to know now that I've joined the club.
There are exercises that certain people with spinal fractures can do, but I'm not going to say them on this podcast because everyone is unique with their fracture. Sometimes they're stable, sometimes they're not, sometimes they're in lots of bits, sometimes just in two pieces. It's very important that you speak to your own healthcare professional and get a proper assessment before trying to do any exercises related to the area that you fractured, whether it's your back, whether it's your fingers, your toes, your leg, your arms, your neck. Just be careful and ask for medical advice.
So, what's your learning this week, Joe?
My learning is that I want a break from any new big projects. So, funnily enough, we recorded an episode this weekend on pacing, which you will have already heard a couple of episodes ago. And it's given me time to reflect. And for the past sort of 5 years or so, alongside whatever I've been doing as my job, whether that was the PhD, whether it's chronic pain research, whether it's working for an app, whether it was working as a physio, there's always been another major project alongside, which you could argue Pain in the Podcast also is a big project that we do together. But I have committed to not taking on any new big projects for the foreseeable future in order that I can have more time to be and pace and not be habitually overactive.
I don't think I'm ready for that. To see you not doing as much as you are, it's going to be weird.
It is odd, isn't it?
Push it to the limit, go past the point of no return.
That's me for the last 15 years. Yeah.
I've known you for 10 plus years, and yeah.
It's very accurate. But yeah, so I'm going to be pacing myself more now in the future. And if you haven't listened to episode 25, I would go back and have a listen, because Amy Forster, a pain specialist OT, does an amazing job of talking through what pacing is and how you can employ it to your life, and that it doesn't just have to mean stripping back activities. It is just finding a way to make things sustainable for you and keep important things in your life.
All right, so let's get things started. Psoriatic arthritis. What the heck is it? Well, it's a long-term autoimmune condition that causes joint pain, swelling, and stiffness, and symptoms can include the things I just said, swelling and stiffness, plus swollen fingers or toes, changes in the colour of your nails, dents forming in your nails, and just feeling lethargic and drained of energy.
Now, as with a lot of inflammatory conditions, anyone out there who experiences an inflammatory condition or who knows someone that does, you might know that symptoms tend to be worst first thing in the morning. And we won't dive too deep into the science here about why symptoms are worse in the morning. We'll do that in the breakdown. But these symptoms often improve throughout the day as you get moving, improve a little bit with exercise.
Yeah, something that I just want to bring into this as well is psoriatic. That's a really strange name. If you've not heard of it before, you might be thinking, what does that sort of link to? So we'll break it down. You've got psoriatic and you've got arthritis. So most people know what arthritis means. It's like inflammation of the joints, swelling, that sort of thing. That's what Don's very eloquently explained there in terms of that process. But psoriatic, that's derived from the same word as psoriasis. So that's
Silent P.
Yeah.
With a silent P. The silent P is important if you're Googling it.
Yeah, please
Always P silently while you're Googling.
Especially if it's at night. And so you may have seen people with the white sort of flaky skin, those what we call plaques, particularly over the what we call the extensor surfaces, so like the elbows and the knee and the front of the knees.
The bendy ones.
Yeah, the bendy ones. Yeah, so that's what the psoriatic comes to. Is the majority of people with psoriatic arthritis either have a personal history of psoriasis or a family history of psoriasis. It's quite rare for you not to have either to then develop psoriatic arthritis, but not impossible.
As someone living with psoriasis yourself, Josh, can you talk us through a little bit about how these kind of plaques develop?
Yeah, so currently I have one very small plaque, which is the first proper plaque I've had in a typical place. That started off as one. You can see it's almost like bilobular.
Yeah.
Started off as one. I've not done anything with it because it's not bothering me. It's gone to two. That will eventually, if I don't do anything with it, will start spreading.
Does it
Basically,
accelerate?
there are things that can exacerbate and alleviate it. We'll talk about those a bit later. But things like alcohol, for example, can cause exacerbations in psoriasis. It will continue to spread without appropriate treatment. But basically what it is the cells that make your skin, keratinocytes, they hyperproliferate. So they just speed up and get a high turnover. So in fact, I think from memory, from reading, it's approximately 30 times the base rate of your normal skin. So it's like your skin is like shedding all normally, but where you've got a plaque of psoriasis, it's doing it 30 times faster, which is why it's making these sort of white scaly areas.
And it's important to note sort of this link between psoriasis and psoriatic arthritis. It's not everyone who gets psoriasis that goes on to develop psoriatic arthritis. It's estimated to be somewhere around 30% of people that actually go on to develop it. So if you are finding yourself experiencing psoriasis at home, it's worth noting that this is a potential condition that you might experience in the future, but also we'll talk through some of the risk factors and some of the preventative strategies that you can use to help prevent yourself developing these arthritis type symptoms.
Yeah, and absolutely. And if you develop psoriasis, it doesn't mean instantly you're going to develop psoriatic arthritis. As I said, 2/3 of people wouldn't develop it. But we see typically from skin manifestation, so those plaques, it's approximately somewhere between 7 and 10 years before somebody would start developing psoriatic arthritis.
So that's a little bit about maybe this link with psoriasis, but do we actually know what causes it then to progress to arthritis?
There is no known cause of psoriatic arthritis, but there does seem to be an increased immune system activation in the skin, intestines, and enthesis. Josh, explanation on what those are?
Yeah, they're tendons and ligaments.
Brilliant. So the increased immune system activation in the skin, intestines, and entheses is initially followed by an increased inflammation due to different stimuli such as mechanical overload, obesity, or infection. And this could still remain asymptomatic, but gradually the immune activation begins to trigger the arthralgia, or enthesis pain, or fatigue and stiffness.
And so it's kind of this three-stage process, right? Is you get that increased immune activation that you don't necessarily know about. You get the inflammation process to start happening, which also it can be what we call sub-threshold, so before the threshold for you to be able to perceive the inflammation. And then finally, it starts to kick off these symptoms that you spoke about.
Yeah, funnily enough, I remember the first time I got a psoriatic plaque was on my back. It was after we
Plaque
went...
on the back?
Yeah, plaque on the back.
How did you see that?
I didn't. I thought it was a fungal infection at first.
Ah.
Me and my university friends, we'd been to a trampoline park, and I'd got like a abrasion on my back. So I thought it was a bit of an infection. I went to the
Because kids, disgusting, trampoline
Exactly,
parks,
sweaty,
not cleaned.
Yeah, exactly. I got some antifungals, didn't work at all. Steroids worked. So something that you can get with psoriasis is something called Koebner's phenomenon, which is where if you get damage to your skin, you can develop psoriasis in that area.
Yeah, right, okay.
So you probably just got like a little bit of an abrasion because of the material, the trampolines, and then that triggered.
Exactly. Was there a bit of bacteria in there as well, which started to increase the inflammatory response? I don't know.
That's really interesting. Well, there you go. Interestingly, for obviously Josh is speaking about psoriasis there rather than psoriatic arthritis, but can we have a think maybe about who tends to get affected by this arthritis?
Yeah, so as I've mentioned, it typically happens between 7 and 10 years after you develop the psoriatic plaques. So it's a bit typically older generation people. So I think the most typical presentation is those in their 60s to 70s. And we say 60s to 70s, but approximately 25% of cases do appear later in life.
And formally, it can appear at any age. There's not something to stop it appearing when they're younger. But yeah, most typically we see it in those kind of, that retirement age population.
Yeah, and if we're looking at the actual percentage of the population as well, it's somewhere between 1 in 1,000 and 1 in 100 people.
Is that just in the UK or around the world?
We actually see that it's more common in Europe than Asia. So if we're thinking about autoimmune conditions, we see that particularly Northern European are more susceptible to autoimmune conditions than, say, Southeast Asia or South America, Africa, that sort of thing.
It's really interesting, isn't it? Because we see now, in a way that we've never really seen before, these spikes in allergies, for example. Yep. It seems like our modern lifestyle, whether that's because of pollution, whether it's because of diet, whether it's because of sort of other lifestyle factors, it seems to be changing the way our immune systems work. Absolutely.
And just going on that as well, is there's a very important hypothesis, which is called the hygiene hypothesis. So people in the Western world have over-sterilized their surroundings.
Just Dettoled the shit out of it.
Yeah, we've Dettoled the shit out of it. So what the theory is that our immune system is used to coming into contact with a lot of bugs, a lot of bacteria, fungi, all of that. And when your body isn't used to dealing with that, so you're not picking fruit off a tree like you used to 100, 200 years ago, you're not coming into contact with like carrots that you've picked from the dirt and not washed properly, that sort of thing. Your body is used to dealing with that. So when everything is completely clean and it's not getting constantly assaulted by those bacteria and those stimuli, it needs something to do. You know, what's the saying? Idle hands make the devil's work, sort of thing. Same sort of thing as with
heard that before.
The immune system.
Oh, right, okay. There's an Asian American comedian called Atsuko Akatsuka, and she has a great bit on that. It's just really funny because she's Asian, her husband's white. And it's just the bit is about allergies and developing allergies and allergies that you get as you get older and within, it's just funny. Go and watch it. There's a
Would you like
YouTube
to know
short.
something interesting and also quite depressing?
Yes, please.
You can become allergic to anything at any point, to even stuff that you use commonly. So like your favourite chocolate bar, for example, you might become allergic to it.
Don't take that away from me, but I have noticed that I am becoming more intolerant to foods.
Ooh.
I'm very fortunate. I just don't have intolerances to any food at this point in my life. I just seem to be able to eat whatever, and it's fine. Whereas some people, I find they just seem to have a list of intolerances as long as your arm.
Yeah.
But also the one thing I struggle with, and this might not be popular with certain listeners, but there is a lot of self-diagnosis of intolerances, and I think it's important, if you want to control your diet safely, go and get medical advice about what you should and shouldn't be eating. Obviously, like, if every time you drink milk you shit yourself, then like probably something's going on with the milk. But equally, when people sort of get a dodgy tummy after eating a takeaway and they decide that now they're intolerant to XYZ, it's like, well, have you considered it could be the dodgy takeaway, it could be the way something's prepared, there could be other factors that made you ill rather than the food.
Yeah, I mean, is it the XYZ or is it the MSG?
No, we're not going to... Don't do this to MSG. It's done so hard to get its reputation back.
I love MSG so much.
Same.
We love MSG. Stop hating on MSG. It was all just propaganda.
It might be terrible for you, I don't know, but it's worth it.
So is everything else.
To be fair, yeah.
Yeah.
Just everything in moderation.
Just go to the doctors if you're shitting yourself after drinking a glass of milk.
Yeah, so... So, moving back over to psoriatic arthritis, Don, I mentioned that the prevalence is roughly between 1 in 100 and 1 in 1,000.
What? Yeah.
But if you have a first-degree relative with a history of it, then you have an 8% chance of developing psoriatic arthritis yourself.
Just to be clear, Josh, can you just tell us what a first-degree relative is?
Yeah, that's mum, dad, or brothers and sisters.
Fab. And in terms of sort of family history, around 40% of psoriatic arthritis cases will have someone in their family, either direct or wider family, that has psoriasis or psoriatic arthritis. So a lot of the cases do seem to be related with some genetic link, but we'll dive a bit more into that later.
What are some other factors that can make psoriatic arthritis worse, Josh?
Smoking, that's a very common thing that worsens psoriasis. But nobody should be smoking. I'm just going to say it. Popular opinion amongst doctors.
Smoking generally will increase inflammation in your body. That's a gross oversimplification, but it's important to note, like anything where there's an inflammatory element, smoking generally makes it worse. There are very few. There's the occasional thing that people will quote smoking is protective against, but usually it's nicotine that's protective against the disease, and it's also very, very uncommon. So 99.99999% of the time, smoking is bad.
Unless it's ulcerative colitis. That's the only thing that smoking makes better, apparently.
Yeah, and we don't know why either.
And I wouldn't even recommend you smoke.
Because the rest of the symptoms you'll get will be worse.
Any more?
Yeah,
Any others?
Being a little chunker, that does that as well.
We're back to the little chunkers again. Yeah, so if you are overweight, fatty tissue is called adipose. That's sort of the scientific name for it. And this adipose tissue makes more of these inflammatory chemicals. And so if you're then getting more inflammation, that's what's more likely to trigger these kind of more aggressive symptoms. And also, if you are more overweight, you put more weight through your ligaments and tendons, so these entheses that Don spoke about earlier on. And that leads to things called microtraumas, which is where you've not like snapped one of your tendons, but you've made like tiny bits of damage to it, which then stimulates inflammation, which again can contribute towards worsening symptoms.
So yeah, thinking of like smoking and obesity and people that already have psoriatic arthritis, Don, you tried to learn the triggers for flares in psoriatic arthritis, didn't you? How did you go about that?
I learned it into a song.
Ooh.
Do you want to hear it?
Yes, please.
So the triggers for flares include stress, smoking, alcohol, injuries or trauma, infections, medications, weather changes, diet.
That was pretty good.
Did you get that?
Yeah, we didn't start the fire. The fire in my joints.
Now, if you could make that song about 3 minutes long, and
Just on repeat. I think that would cause a lot of trauma.
Sorry, just harking back again after that beautiful song, Don, to things that are associated with an increased risk of developing psoriatic arthritis. There's been arguments over the years in science about whether the severity of someone's psoriasis is associated with greater chance of developing psoriatic arthritis. And some people said yes, some people said no. But recently there's a big paper that came out that basically said if you have psoriatic lesions like these plaques Josh spoke about, or the kind of precursor to them, which is kind of like a redness and a breaking down of the skin, If that covers 3 to 10% of your whole body surface, then you've got a 44% increased risk of developing psoriatic arthritis compared to people who don't have plaques. Whereas if it covers more than 10% of your body, there's a 101% increased chance. So you're twice as likely as someone without plaques to develop psoriatic arthritis if you have 10% or more of your body covered with plaques.
Wow, Donald Trump would have a terrible time understanding all these percentages.
1,500%, 600, 500%. I have a special talent that I've used with the drug companies. I don't know why he's so camp. I have a very special talent that I've used with the drug companies. But also, it's not just the amount of your body that's covered by lesions. Also, the location seems to be associated as well, doesn't it, Don?
Yeah, so the location of these skin lesions seems to be associated with different likelihoods of developing psoriatic arthritis, with a twofold increase in intergluteal plaques on your lower back.
In the crack.
Plaques in the crack. And a threefold increase with nail area plaques, and a fourfold increase with scalp plaques.
So we don't know why that is at all, but it just seems that these different locations are
more likely to develop those plaques.
So that's a little bit about maybe some of the things that could increase your risk or might be associated with higher chance of developing psoriatic arthritis. But what sort of symptoms? We've briefly touched on these at the beginning, but what symptoms do people tend to experience with psoriatic arthritis?
So yeah, the typical symptoms are synovitis. We mentioned this in rheumatoid arthritis as well, but that's triggered by the immune-related overreaction of chondrocytes, which are bone cells effectively, and fibroblasts in the joints. The swelling of these joints in psoriatic arthritis can be separated from other inflammatory arthritis by the purplish discoloration of the joint. We've already mentioned skin lesions. Just to say, like, bit of flaking skin doesn't hurt whatsoever. They're almost insensate, if we're being completely honest. Can't feel anything through them at all. Yeah. They're not infectious. You can't spread them to other people. Yeah, some common misconceptions.
Yeah. It's more aesthetic than anything else.
Yeah, one of the other key symptoms as well is bone resorption, so like erosion of the bone. So typically when we talk about this as a typical radiological finding, which is what we call like penciling cup. So if you look at an x-ray of the hands, it's sort of erosions of the proximal part of a bone compared to the other end, so it looks like almost like an arrow pointing down into a flatter surface. Right. We'll put a picture in somewhere.
Yeah, just to give a bit of visual input for people there.
Yeah.
But those things tend to happen because when you've got overactivation of your immune system, you might remember from previous episodes on RA, we spoke about osteoclasts and osteoblasts. So osteoblasts, B for building, they help to build new bone, and osteoclasts we decided was for collapse or crushing because they're the ones that break down the bone. And that's just a normal kind of turnover in your body. But when the immune system's overactive, you get too much osteoclast activity and it starts to thin your bones down. Yeah. It's very important to note as well, this doesn't happen from day one of having psoriatic arthritis, and early treatment is very key for preventing these, because once you've got these erosions, it's quite hard to reverse that kind of effect. So the earlier we catch and treat psoriatic arthritis, the better.
Which is why it's so important to go to see your doctor.
Mm-hmm. There's almost a theme running through this podcast, isn't it?
There almost is. It's just see your doctor, even if it's just for a cup of tea.
Now, we've also seen a lot of differences in the type of symptoms that people experience depending on gender. So female patients tend to have more peripheral symptoms, and Joe, would you like to give a little brief description of peripheral symptoms?
Yeah, so when you hear people speak about axial, so like when we did our episode on axial spa, axial basically means in your trunk, so things like your spine and your centre.
Cool.
Whereas, exactly, like through the middle of your body, whereas your wider body, so your head, your arms, your legs, limbs, all the stuff that's away from your centre is your peripheral.
Yes.
So peripheral symptoms in this case might be that inflammation of your ligaments and tendons.
Yeah. So yeah, female patients tend to have more of these peripheral symptoms with less radiographic progression, but they also have worse pain averages and experience more fatigue and function.
Yeah, so in terms of radiographic progression, what that means is their symptoms show up less on x-rays. So with a man, traditionally, with PSA, you might see people who have sort of more obvious bone erosions, for example, whereas women it seems to be less clear. But Josh, I think you had a little bit of a look at sort of how sex hormones might be the reason for why.
Yeah, so from what I can see from my research is that when it comes to pain in females, it may be a result of estrogen triggering increased production of the pro-inflammatory cytokines, so those proteins that your body makes to cause inflammation. So you may have remember from the rheumatoid arthritis, there's TNF alpha, there's interleukin 1, interleukin 6. If you're really a nerd like me and Joe are, you can check what these are and what they do. I'm not going to lie, it's not fun, but it might be interesting. Whereas in men, testosterone and progesterone can stimulate the production of anti-inflammatory cytokines. So those proteins that counteract the inflammatory ones. So that's things like interleukin 4, 5, and 10.
So what does that mean then?
Basically, if you've got more estrogen, you're more likely to produce inflammatory proteins. If you're a man, because you've got higher levels of testosterone compared to women, you're more likely to produce anti-inflammatory proteins. This is just in relation to psoriatic arthritis. This isn't overall a general thing.
But there are really interesting conversations in inflammatory conditions about supplementing women with testosterone. We'll put some references to kind of this being discussed among scientists and how this has started to be used, because some people claim that they've had massive improvements in symptoms of inflammatory conditions after having supplemented testosterone.
Wow.
Yeah. And just to hark back as well, just about how important it is to see a doctor early is if you present late, you're more likely to have these issues with your articular surfaces, so with your bones and joints. So
yeah,
we need to treat early.
Exactly. And speaking of these bones and joints, psoriatic arthritis is a very changeable clinical presentation over time, so if you don't treat it, it likely gets worse. But there is kind of a general classification, if you have PSA or know someone that does. It can either be something called distal interphalangeal joint arthritis, which is basically the little joints at the end of your fingers, sort of the last couple of joints at the end of your fingers.
Ones that bend. Yeah.
The ones that bend. It's getting arthritis in there, so you might see some sort of classic deformities that are usually more associated with rheumatoid arthritis, but you can get these kind of deformities and swellings at the end of the fingers, kind of fingers looking a little bit odd in their shape.
Heberden's nodes.
Exactly, Heberden's nodes if you want to Google them. About sort of 15 to 25% of cases are things called asymmetrical oligoarthritis, oligo meaning few, which basically means it only affects a few joints and it's not symmetrical on both sides. Somewhere between sort of 60 and 70% of cases are polyarthritis, which basically poly means lots, so it affects loads of different places. There's spondylitis, which you might remember from axial spondylar arthropathy or ankylosing spondylitis, affects the middle, so your trunk. And then there's arthritis mutilans, which is actually very, very severe and causes extensive damage to joints throughout the body, but thankfully is a lot more rare than other subtypes. So if you know someone who's got it or you have it yourself and you see these terms that you don't really understand, hopefully that's a bit more clarification.
Okay, so yeah, you think you might have psoriatic arthritis, you've got psoriasis and you've got joint pain. How do we go about diagnosing it and getting you the treatment that you need?
Well, there is no definitive diagnostic test for psoriatic arthritis, but a quick way of diagnosing it is using the Pure 4 questionnaire. Joe, what is this?
So this is 4 key symptoms, which when you're positive for all of them, capture about 86% of cases of psoriatic arthritis. So they capture the majority of them, and they're pretty specific. So they're good at capturing psoriatic arthritis, and they're also good at excluding other similar conditions. So the 4 signs that you're looking out for are signs of dactylitis, so that's swollen fingers. So if you imagine like you've got, in the politest possible way, a bit of sausage finger. If you've got a finger like King Charles...
Oh, I was picturing everything everywhere all at once.
I've not watched it, sorry.
Hot dog fingers, they'll know.
Okay. Inflammatory pain in your heels as well, so this sort of enthesitis we're talking about in your Achilles tendon. Pain in both your buttocks, and if you're over 50 years old, having joint pain and swelling in your periphery, so things like your knees, your ankles, your hands. These 4 symptoms altogether are a pretty good way to get an idea of whether you might have psoriatic arthritis.
Yeah, and some clinicians advocate for the use of blood biomarkers, which can show like the inflammatory process, but some studies say that this isn't really that conclusive.
Yeah. So in the future, we might end up doing just a blood test for psoriatic arthritis, but actually at the minute, it's not a perfect method. So a lot of it, as Josh can tell you from a clinical point of view, it all comes down to sort of your clinical judgment as to whether you think the person fits the picture.
Yeah, absolutely.
And in terms of sort of diagnosis, there are different genetic markers that indicate how severe your symptoms are going to be. So we won't dive into these too much because we'd basically just be listing names. But if anyone is particularly interested, you can reach out to us and we can explain to you what tests they might do, what they might be looking out for, and how that would affect your psoriasis symptoms. Interestingly as well, in individuals where there's psoriatic arthritis compared to individuals with just psoriasis, there seems to be sort of modifications of the DNA in their cells called CD8 T cells, which are basically immune cells which go around and help to kill the things that you don't want in your body. But also in conditions like this, they unfortunately act against your own cells. So it seems like there's this modification that's changing these patients from just having psoriasis to having this full-on inflammatory arthritis condition as well, which obviously further down the line might be something that we would try to target clinically from a drug's point of view.
So you might be thinking about how scans can help diagnose these things. And conventional radiography such as x-rays can only really assess the later stages of the disease, characterized by like bone erosions, as we mentioned before, and soft tissue changes, whereas high-resolution CT scans can catch lesions in the joints much earlier, and so can MRI scans. Ultrasound scans can also be used to assess joint changes like inflammation of the entheses or joint swelling and in synovial hypertrophy.
Which is basically where the lining of your joints becomes overactive and swollen. And that's a sign of something like an inflammatory arthritis. So that's a little bit then about how it might be diagnosed and what you can expect if you suspect that you might have this condition. But unfortunately, as with a lot of these inflammatory conditions, there tend to be a lot of conditions that people often get as well, like alongside this, conditions that tend to coexist.
Yeah, we call those extra-articular manifestations. So that's symptoms that don't affect the joints or the bones.
And so what sort of things might we see?
Yeah, we mentioned them all in our rheumatoid arthritis episode. Harken back, just go watch that as well. Directly after you've watched this one.
Yeah, you have not plugged that episode enough in this one.
No, we need to plug it more. So those symptoms are things like uveitis, that's swelling of the uvea of the eye.
What's the uvea of the eye?
This bit.
Genuinely don't know what that is.
We'll put a picture of what point Josh was pointing to when he said this bit, so you can understand at home.
It's better to show a picture rather than me to try to bumble through some words.
I've never heard that before.
You heard it in the rheumatoid arthritis.
Oh, yes, I did.
He wasn't listening. But you should go and listen to it in case we haven't plugged it enough.
Yeah, inflammatory bowel disease is a link between psoriatic arthritis and causing flares of inflammatory bowel disease. Cardiovascular disease, so rather interestingly, there's a 43% increased risk compared to the general population. Metabolic syndrome, so that's things like pre-diabetes and raised blood sugars, as well as type 2 diabetes by itself, and as well as liver abnormalities. So we see that in approximately 1 in 3 patients, they've got issues with the liver. This is typically due to that greater inflammatory response that the body's doing, so that milieu of those proteins causing issues.
And also, some of the drugs that we use to treat it, which we'll get onto shortly, can be really quite aggressive on the liver. Something called hepatotoxic. So whenever you're seeing something written medically about the liver, it will be hepato something. Hepatomegaly, big liver. I like that word. So these drugs can be hepatotoxic.
Yeah, and the real thing that we want to look at is what we call outcome measures. So that's how severe is your psoriatic arthritis right now. And that's important because it lets us see progression. It lets us see how we're doing with specific medications and treatment methodologies. So there's things like, we won't go through all of them, but there's things like DASPA, which is disease activity in psoriatic arthritis. There's things like BASDAI. There are multiple others. It all depends on your rheumatologist, your doctor, regarding which method they use. But it's quite important with this one is that we use the same one because if we go for different ones, they check slightly different things. So you might get a higher score on the BASDAI compared to the DASPA. So that's why it's important about having the same sort of point of reference. So that continuity of care, so seeing the same doctor, which everybody likes to do, rather than seeing different doctors every time they go see somebody, and having that continuity with the scoring methods for outcome measures. That's the only way that we can tell really accurately if we're helping you, if you're progressing, or anything like that.
And exactly like we said in the rheumatoid arthritis episode, if you happen to move house and you have one of these conditions, ask for your medical notes. You have complete right as a patient to request them, and find out what measure they were using, because exactly as Josh said, if they start using a different method, it's comparing apples and pears.
Yeah.
And so you might think that things are way worse because you've got a higher number score, but you don't know that your first score was 7 out of 10 and your second score was 30 out of 50, but you go, oh God, I'm scoring a 30 out of 10. You know.
And like as a doctor, when I'm seeing patients as well, quite often we call them out of area patients. So if you've recently moved or you're on holiday, for example, it's very difficult for us to find your medical records because not everybody uses the same computer system.
And so once you've then thought about tracking the symptoms, once you've got these outcome measures, obviously we're not tracking them just for the sake of bringing patients into the hospital and saying, hey, tell me how it's going. And then we list them and we go, okay, you can leave now. The whole point...
You're getting much worse. Well, see you next week.
But it's important to note that we're tracking these things because we want to see how they're responding to treatment. So we've got a tiny bit to discuss about prevention. So if you are suffering with psoriasis and you want to limit the chance of getting psoriatic arthritis, and then plenty of things to talk about in terms of how it's actually treated. So Don, do you want to talk us through what we found about prevention?
Yes, so patients with moderate to severe plaque psoriasis were nearly twice as likely to develop psoriatic arthritis if their plaques were managed with UV light therapy as opposed to if biologics were used.
Do you want to talk us through what biologics are?
Yeah. So biologics, I always struggle to say this, biologics. Biologics are drugs that focus on specific inflammatory molecules.
Josh, you mentioned this earlier on about sunlight being good for psoriasis. I'm guessing that's why UV light therapy would be used.
That's exactly right. Just a bit of an anecdote from my own history. My dad had psoriasis, and he went through this PUVA, so that UVA light therapy. And he used to go in his... My dad was an overweight gentleman as well. He used to have a pair of Speedos and a set of almost like swimming goggles that are tight and protected for his eyes.
Are they the ones with the little teeny tiny holes so you can see out of them?
No. It's like mirrored sort of thing,
right?
So that it can't penetrate. And he'd stand there in his this stand-up sunbed sort of thing, come out looking like he's been to Spain. Yeah, it works. It does work.
But like we say, if you've got psoriasis and you're being managed with this, it might be worth having that discussion with your doctors about whether biologics might be appropriate for helping to prevent these arthritis symptoms. So moving on from that prevention of psoriatic arthritis to treatment, as with a lot of different inflammatory arthritises, the treatment begins with NSAIDs, which we've spoken about before, things like ibuprofen, naproxen, just to bring that overall inflammatory response down. But what do they then progress to? If these aren't working well enough, or if they want to get your symptoms more under control, what comes next?
Well, actually, there has been a very recent shift. So previously you had to wait for a good several months of treatment with DMARDs before you moved on to biologics. But we're actually seeing, as soon as you get a diagnosis, we start biologics because all the evidence now is showing that it improves in terms of decreasing disease progression. So I went for my assessment, and in that first consultation, my rheumatologist gave me a leaflet about the biologics so that if the scans showed that I had psoriatic arthritis, or if all the blood showed that, then they could start it straight away rather than delaying it. So yeah, sorry to interject, Joe, but previously you'd have to wait and we'd have to go through this stepwise, but now we're being very aggressive with the treatment because we know how it can just rapidly progress and we need to get it under control.
So you've both mentioned different types of treatment, DMARDs and biologics. What can a patient expect this to look like in a physical sense?
Yeah, very good question, Don. So biologics, it's not just taking a tablet. Typically, it's going in every couple of weeks for an injection, an IV infusion. And as I've said in other episodes, every medication that works has side effects.
Yeah. Some of the biologics target TNF alpha, one of these inflammatory chemicals we've spoken about, and actually because that's such an important immune molecule, if you're basically switching off its activity, you're at increased risk of infections, especially if you've had TB and it's now under control. Switching off this much of your immune system often means that people who have had TB in the past get exacerbations of it again. But also, we don't typically think of this, but the immune system's really important in preventing cancer. And so if you're taking TNF inhibitors, actually it can increase your risk of cancer. I'm not saying everyone who takes TNF inhibitors is going to end up getting cancer, but there is an increased risk, and it's important that we're candid about some of the side effects.
Yeah, and this is why it's important to have that consultation with your rheumatologist, your doctor, and read all the information so you can make an informed decision about things. But I mean, Don, you was looking at some ways in which we don't use medications, but lifestyle changes, wasn't you?
Yeah, so these are really important because it gives people another option, and that can include exercise, regular exercise, particularly low-impact activities like swimming, walking, and yoga. These can be used to strengthen. Another one could be cutting down on alcohol, as it can definitely impact the effectiveness of medication.
Yeah, and we said it was a trigger for psoriatic arthritis as well.
Yeah.
So why would you continue with triggers?
And then also an obvious one, as you've mentioned before, smoking. Bad.
Yeah, stopping smoking is really valuable in treating your psoriatic arthritis. I also, just kind of tying these things together to give a bit more of a clear picture to people at home, Don mentions these low-impact activities. You might remember we said that in people who are obese, you get this micro-trauma, so these kind of repetitive small traumas on your ligaments, on your tendons. So that's why they're recommending low-impact exercise. Generally, wherever we can, we recommend weight-bearing exercise, we recommend stuff that puts load through your joints, but actually that's the reason why there's a recommendation for lower impact stuff in these people with PSA.
We've mentioned about the genetic element, so that heritable sort of part of psoriatic arthritis. There is, moving forward, a bigger focus on how our own genomes and our genes that we express affect the effectiveness of the medications that we choose. So it may actually be possible within the next 10 to 20 years that we would be screening for which genes a specific patient has, so we can specifically target the therapy that's going to be best for that person. I think that's a very exciting sort of progression. You think about it, like if you've got very severe disease now, there may be future treatment options that become available and just make things a lot better.
Yeah.
Exactly, and that really is an exciting future, this idea of a more personalised medicine. Hopefully within our lifetimes we will see medications being used a lot more targeted towards sort of specific individuals.
So, well, we've talked a lot about psoriatic arthritis there. So I think that just leaves us with a book review this week, doesn't it, Joe?
It does. This week we are reviewing Milk of Paradise by Lucy Inglis.
Delicious.
Love opioids.
How did you know? The reason why it's called Milk of Paradise, Josh, do you want to shed light on this? You immediately twigged that was opioids.
Poppy milk.
Yeah.
Oh, well done. Yeah, crack on.
No, that's all I know, poppy milk. Josh, take it away.
Yeah, so to get opium from poppies, you sort of like cut them and they sort of release a milky substance, which contains opioids.
There you go. And so this book, as you can probably guess from both Josh and Don's response there, is about the history of opium, which if you've listened to episodes 1 and 2 of our podcast, you will know we have talked and laughed a lot about. But it's really interesting. It goes all the way from sort of 7,000 years BCE all the way through to the modern day and the opioid crisis. So if you want to get a really good picture from the first ever medication that we know of people using consistently, like cultivating plants for medication, it's a really good read. And actually, hint, hint, for our 1-year anniversary episode, you might actually hear us referencing more about opium.
Can't wait for that.
And so, until then, listen to the breakdown, subscribe to us on Patreon if you feel generous, or if you don't, please. And we will see you in a fortnight's time.
Ciao.
Goodbye.
Goodbye.